Hello and welcome back to Goethe CVI webinar series. My name is Valentina Puntman, and today I'm going to take you through some of the fundamentals of late gadolinium enhancement imaging. We will begin with physiological basis of late gadolinium enhancement, move on to image contrast development, and then lastly review the clinical applications, interpretation and reporting. The basic idea of late gadolinium enhancement is the binary readout of black and white, with white representing the area of myocardial injury, against black normal, preserved, remote and viable myocardium. The imaging readout of black and white is possible due to differential accumulation of gadolinium-based contrast agents, with a greater uptake in abnormal myocardium, for instance, due to disrupted cell membranes in the course of ischemic injury, or due to expanded interstitial space in a process of reparative myocardial fibrosis. Gadolinium-based contrast agents are gadolinium chelates which are used as intravenous agents for contrast enhancement imaging by MRI. Mechanistically, they work on a principle of shortening the rate of T1 relaxation within the tissues where they accumulate. These agents are generally well tolerated, with allergic reactions being exceedingly rare. A few years back, they've been associated with a serious adverse condition called nephrogenic systemic sclerosis. The unifying circumstances described in these cases were the presence of severe kidney impairment, the use of high and repeated doses in too short time intervals, as well as the use of high-risk agents. These are the ones with the less tightly bound gadolinium within its chelate. This knowledge led to develop a guidance on the prudent use of gadolinium-based contrast agents in clinical routine, and with no new cases reported ever since its application. Moving on to the image contrast development, which is based on a differential uptake of gadolinium-based contrast agents, as well as regionally segregated, allowing us to recognize them as two different types of tissues. Late gadolinium enhancement as black and white binary readout works best when tissues are clearly different as well as demarcated one from another, as opposed to diffuse changes in the myocardium, giving a contrast in shades of gray. Image contrast in late gadolinium enhancement is defined by help of look-locker sequence. This is a T1 mapping sequence that is based on a regional report of doctors Luke and Locker in 1970. This sequence, also known as a TI Scout or TI Prepulse Finder, serves to map out the course of recovery of longitudinal relaxation and helps to identify the correct imaging time for optimal imaging contrast, that is, as white and as black as possible. Just a touch of MR physics to illustrate how this all works. The first step is preparation of magnetization by using inversion recovery prepulse. That means that we flip magnetization that is normally oriented from foot to head alongside the main magnetic field 180 degrees. That means now it's looking into the opposite direction. And now comes the main part, the recovery of magnetization from looking towards the foot back towards the head as it recovers into its original orientation. This process we follow step by step using look-locker sequence. Here above come the separate images obtained with look-locker sequence as T1 relaxation recovers with time. One can observe bright images at the beginning of the process, turning dark in the middle of it, and again return to bright images at the end of it. This is mirrored in our signal-to-time relationship curve, with a decrease of signal to the point of crossing 90 degrees or null point, followed by an increase in signal as magnetization recovers into its original position. We are trying to identify the image with the greatest contrast, that is, between the black myocardium and white scar, providing a prepulse delay time, which we use in subsequent late gadolinium enhancement imaging in short axis and long axis acquisitions. Optimal TI is a moving target. That means that our null point optimally chosen pre-pulse delay for black myocardium, with time starts moving along the curve on the left-hand side towards the brighter images. Acquisition of a short-axis tag takes a certain amount of time, between 3 to 5 minutes, dependent on the size of the ventricle. To account for the time required to complete a short-axis acquisition, we routinely add an amount of time, let's say 10 milliseconds, to our optimally chosen pre-pulse delay. By this we ensure that as the time passes, we will be moving through the null point, as opposed to away from it. Important point in acquisition of late gadolinium enhancement is that we verify bright areas in 2 orthogonal views. And finally, clinical applications. Late gadolinium enhancement has been developed with ischemic heart disease in mind. It helps to recognize a previous myocardial infarction based on the visualization of myocardial skull. And that is across the whole range of transmuralities, from full thickness 100% transmural scar to less than 25%, which goes frequently undetected by SPECT imaging. Recognition of a previous myocardial infarction, however small, has bearings for prognosis, and this has been shown in a multitude of studies. Late gadolinium enhancement can guide clinical management by assessment of viable myocardium. That is, whether myocardial tissue that is impaired, hypokinetic, and dysfunctional stands a chance of recovery with revascularization, something that is highly dependent on the transmurality of myocardial infarction, whereas improvement can be expected in partial thickness myocardial infarction. A full thickness scar is unlikely to recover. Late gadolinium enhancement, as well as its modification early gadolinium enhancement, are presently the most accurate techniques in identification and follow-up of LV thrombi. Early gadolinium enhancement aims to visualize structures with no or relatively little uptake of gadolinium contrast agents within the first few minutes after administration, using the same sequences as well as the same geometries as late gadolinium enhancement. TI is chosen arbitrarily long, commonly around 400 millisec. Whereas primarily not intended, late gadolinium enhancement can be also helpful in recognition of non-ischemic heart disease based on late gadolinium enhancement patterns, including mid-wall stria in dilative cardiomyopathy, epicardial late gadolinium enhancement in convalescent myocarditis, intramyocardial patches of granulomas in sarcoidosis, intramyocardial diffuse late gadolinium enhancement in hypertrophic cardiomyopathy, and pathognomonic appearance of late gadolinium enhancement in cardiac amyloidosis with black blood against black myocardium. Also common in non-ischemic cardiomyopathies is a rim of pericardial enhancement. Together with a septal flattening with inspiration, this may indicate increased right ventricular pressures and constrictive physiology. We will conclude with late gadolinium enhancement checklist based on SCMR document for standardized image interpretation and post-processing. Firstly, the presence of late gadolinium enhancement is defined as high signal intensity area, as bright as the LV blood pool, after having ruled out the possible artifacts. Next, we assess pattern of late gadolinium enhancement, which can be ischemic or non-ischemic. Ischemic pattern of late gadolinium enhancement is subendocardial and consistent with perfusion territory of coronary artery. Non-ischemic type of late gadolinium enhancement spares subendocardium, however can be found elsewhere, such as midwall or epicardium, and can be occasionally transmural. However, it does not follow the territory of a coronary artery. When describing late gadolinium enhancement, its location and extent are important, and for this we use AHA 17-segment model. This allows comparison of late gadolinium enhancement with other relevant images, such as cine or perfusion images, to correctly categorize ischemia and viability. And lastly, average transmurality of late gadolinium within each segment. This is a quick guide to interpretation of ischemic late gadolinium enhancement for assessment of viability. We declare a postmyocardial infarction or ischemic scar within a particular vessel territory. Based on transmurality of the scar, we indicate the following likelihoods of viability. Myocardial scar with up to 50% of transmurality indicates significant viability and high likelihood of recovery. Transmurality between 50 to 75 is associated with low likelihood of functional recovery. And finally, with a full thickness scar, the recovery is altogether unlikely. Quantification of late gadolinium enhancement as a percentage of a total myocardial mass, while not yet a clinical tool, is certainly gaining interest. In summary, we've looked at the fundamental principles underlying the late gadolinium enhancement imaging. We reviewed physiological basis of late gadolinium enhancement and its ways of revealing abnormal myocardium by differential uptake of gadolinium-based contrast agents. We've looked at the development of black and white imaging readout based on the regionally segregated myocardial tissues, as well as at the role of look-locker sequence in optimization of the imaging contrast. And finally, we've reviewed clinical applications, interpretation and reporting in ischemic and non-ischemic heart disease. Here are the sources I've used in today's presentation. I hope you've enjoyed this webinar and I would like to thank you for your attention.